Good evening, everybody, and welcome to our webinar, COVID-19 Awareness, Upsilonians in the Frontlines. My name is Ricky Rionda, an Upsilonian from batch 83, and I will be one of your moderators tonight. We would like to welcome all our broads and all our participants in the United States, the Philippines, and from all over the world. This webinar is being brought to you under the auspices of the Upsilon Sigma Phi Alumni Association of North America, its mother chapter, the Upsilon Sigma Phi Alumni Association in the Philippines, and our sponsor, LBC Express, now on its 70th year of bringing smiles to your home through its sea and air cargo balikbayan boxes and money remittance service. With LBC's contactless and safe pickup, you can now book online at lbcexpress.com or by visiting the LBC Facebook page, LBC Express Inc., to schedule your balikbayan box pickup. LBC, tuloy pa rin ang paghatid namin ng Pasko. Before we begin our webinar tonight, let me introduce to you the president of the Upsilon Sigma Phi Alumni Association of North America, fellow George Nolasco, Upsilonian batch 1967, for his welcome remarks.
Good evening to our USA audience at magandang umaga to our Filipino kababayans and friends. We welcome you all today to our timely and helpful COVID-19 awareness Zoominar. I am G. Nolasco, President of the Upsilon Sigma Phi Association of North America. This Zoominar is a public service to all our brothers, sis, and kababayans all over the world. We thank all our distinguished speakers, our brother Upsilonian frontliners, Dr. Yuli Manalang, Professor of Medicine, Ohio State University, Dr. Emmer Coronel, Internal Medicine, MedStar Health, Attorney Inky Reyes of the Philippine Red Cross Board of Governors, Mr. Ted Tesoro, COVID-19 survivor, LBC Express Cargo Sales and Marketing Specialist, experienced panelist, Dr. Ted Herbosa, Special Advisor to the PI COVID-19 National Task Force, Xavier Key, Mid-Atlantic Permanente Medical Group, our organizer, Brad Ricky Rionda, and moderator, Mike San Juan, both of batch 83. Audience is encouraged and send this questions through chat and clicking or selecting moderator Mike. We also sponsor LBC, a freight forwarding service, as Brad Rafi Policarpio, 76, and Ted Tesoro for their sponsorship. And now back to you, Brad Ricky.
Thank you, Mr. President. Tonight, we are going to talk about COVID, 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 like our lives depended on it. This raging pandemic is the most devastating medical catastrophe to ever hit the world in the last 100 years. As of Friday, December 4th, over 66 million cases have been reported worldwide, with over 1.5 million deaths. In the United States alone, over 14.5 million cases, with close to 283,000 deaths. In the Philippines, 435,000 cases and close to 8,500 deaths. The US is in the midst of a deadly winter surge in cases, with hospitalizations surpassing 100,000. Last Thursday, The US set single-day records for new infections at 212,000 and deaths at 2,858. Now, hospitals in many US states are at or near capacity and running out of ICU beds. One person dies of COVID in the US every 30 seconds. And by the time we finish this webinar, another 240 Americans would have died from the virus. The latest models project that US deaths will rise to 538,000 by the end of March 2021, with or without a vaccine. And we cannot even begin to understand the tremendous toll this pandemic has wreaked on the global economy. Millions have lost their jobs. Businesses have been shuttered, and many of them permanently. Many are facing eviction from their homes with no money to pay for mortgages or rent, and people are going hungry. The new $900 billion bipartisan relief proposal has reached an impasse in the US Senate. So you probably saw the many thousands who lined up for groceries at a food bank distribution event in Dallas right before Thanksgiving Day. And we probably can also say with certainty that this virus was responsible for bringing down a presidency simply for a seemingly lack of coherent strategy where even mask wearing was weaponized. But indeed, the worst thing that ever happened was for this pandemic to occur in an election year. So let's talk about COVID, COVID, COVID. Tonight, we have a panel of experts to help us navigate this world of COVID. We have a member of the academe who will talk about therapeutics and vaccines. We have primary care practitioners who are boots on the ground to talk about the surge and to discuss prevention and care. We have disaster management experts who will talk about the virus in the Philippines setting. And we will also be joined tonight by a COVID survivor who will tell us about his personal journey from sickness to recovery. They are all alumni of the University of the Philippines and the Upsilon Sigma Phi. And like hundreds of Upsilonians doing their part in fighting the pandemic as medical professionals, doctors and nurses and technicians, researchers, teachers, local government and public officials, members of the Philippine legislature, and volunteers, they are all Upsilonians in the Frontlines. But before I introduce our first presenter this evening, here are a few housekeeping rules. We have muted everyone except our speakers. We will have a 45-minute question and answer segment after all our speakers have presented. If you have any questions, please type your questions in our chat box. And if you wish to address your questions to a specific speaker or presenter, please indicate that as well in your question. Now we will also be giving away three $100 gift certificates courtesy of our sponsor LBC Express during our Q&A portion. So please stick around. And you can also sign up with your name, email, and state or country in the link provided in the chat room to receive a discount from LBC Express, $10 off sea cargo, 10% off air cargo, and money remittance. You can also send a private mail to Brad Ted Tesoro and give him your name, email, and your state and country. Okay, so let me introduce to you our first speaker tonight. Our first speaker tonight is Dr. Emerson Cornell, Upsilonian, batch 78. Dr. Coronel is an internal medicine physician with MedStar Health since 1996. MedStar Health is one of the largest healthcare provider organizations in the Baltimore, Washington metropolitan area. Dr. Cornell has been recognized by the National Committee for Quality Assurance and the American Diabetes Association for his skill in providing the highest level of care. So please welcome Dr. Emmer Coronel.
Thank you, Ricky. Greetings, fellows, sisters, and friends. I'm here to talk about COVID-19. Excuse me while I try to get my
There, correct.
Here we go. So I'm here to talk about COVID-19 infection in the primary care setting. To those of you who don't know me, I'm an internist in the Washington, D.C. area, where we take care of 1,700 active patients, 46 COVID cases with 3 deaths. I'm also the medical officer of a congregate living facility for the Catholic religious, where we have a rotating international clientele of 70 individuals, 30 cases, and 1 death. In other words, I represent the typical primary care provider in a cosmopolitan suburban area. We are one of 3 choices you will call on if COVID-19 symptoms develop. The other 2 being urgent care clinics and hospital emergency rooms. So what do we do in the outpatient setting? To explain, I will briefly touch on the ongoing winter surge, review everyone on items 2 to 4, and briefly go into the outpatient treatment currently available to us. From 1 case of COVID-19 in January 20 of this year to almost 100,000 cases a day 9 months later, to over 200,000 cases a day less than a month after that. Currently, hospitals are being overwhelmed, and 2 Americans are dying every minute. The 3rd wave is clearly here, and we still have the holiday season to deal with. To quote Game of Thrones, winter is coming. But instead of the Night King as an adversary, we have an amalgamation of nucleic acid, fats, and protein molecules that look like an embryo from that 1987 horror flick, Hellraisers. On a personal level, dear friends, if your extended family pod has been spared from this virus so far, statistically, 1 or 2 will be by the end of the holiday season. So, briefly, how do we get this virus in the first place? Coughing, sneezing, laughing, shouting, singing, talking, in other words, just simply being alive, will produce aerosols and droplets. What are aerosols? Very fine droplets. What are droplets? Very heavy aerosols. Aerosol, you inhale, you get infected. Droplets falls to a surface, you touch the surface, you touch your face, you get infected. So what do we do to prevent this? On the upper left corner, I call that the big 3. Everyone over 2 years old should be wearing a mask. Double cloth is better than single cloth. Snug is better than loose. Social distancing, 6 feet is good, 10 feet is better. Hand washing, obsessively. Lather for 20 seconds, then rinse. Singing happy birthday won't cut it anymore, unless you sing it in adagio, I guess. For sanitizing, it doesn't matter if it's isopropyl or ethanol, as long as it's 60% alcohol. Read the labels. On the box on the right, I call that the sixth man. You still need him to win the basketball game. Not touching one's face. Remember the droplet transmission I mentioned earlier? Following local guidelines. I agree, controversial at times, but always timely and generally well thought of. It works best when everybody's on board. Staying healthy, de-stress, sleep well, eat healthy, hydrate, exercise judiciously, control chronic medical illnesses if you have them. To these 6 items above, I would add a 7th category, prayers for the religious amongst us. Hope and trust to science and statistics for our more agnostic friends. You see, if you do the big 3 on the left, the 6th man on the right, you pray, hope for the best, and trust the science. In my opinion, the virus doesn't stand a chance. Then why the pandemic, you ask? One word, consistency. All of us can do all those things that I mentioned earlier, but you can do it for a week, maybe a month at most, but we have to do it for months at a time to be successful. That's the problem, consistency. And that, my friends, is why we need the star of tonight's show, the game changer, the silver bullet, the cavalry that will turn the tide of this battle. Heck, dragon glass, an effective and safe vaccine. Fellow Yuli Magalang will discuss this on the next segment. Please listen well. Moving on, if you do fail prevention and you get exposed, defined as exposure of contact less than 6 feet for 15 minutes or more. That's cumulative time. Say you're in an outside bar and you are drinking with friends and everybody's protecting themselves. If, however, you go into that bar ordering a drink, spending 3 minutes to order your drink, chit-chatting with a nice-looking bartender, and you do that 5 times, that's 15 minutes. Even if it's over 3 to 4 hours, that's still considered exposure if the bartender is unprotected and it's in a closed environment. If that happens, and then 2 days later, you hear from the local grapevine that he became positive for COVID, then you have to quarantine for 14 days, 10 days now, not 14, it used to be 14. And then you watch for symptoms. Ordinarily, when people hear that they've been exposed, they go for testing. Not really needed at that time, but it can't hurt. It may be useful for certain situations. During the 10-day quarantine, you have to watch for symptoms. 38 degrees or 138 degrees Celsius or 104 degrees Fahrenheit, dry cough, getting winded, just doing normal daily activity. And on the right column are the other associated signs of COVID: fatigue, body aches, headaches, loss of taste or smell, sore throat, congested or runny nose, and diarrhea. If you develop these conditions or symptoms, then you go for testing. There are 4 major categories. The antigen test, also known as rapid test, also known as lateral flow test. And then there's the PCR or molecular test, and the antibody or serologic test, and the viral culture, the gold standard, mainly used for research. Now, for specifics regarding these tests, feel free to join our Q&A later. But for most of us, the concern really is just 2 things: accuracy and speed. False positive, false negative. False positive is when you test positive, but you don't have the disease. False negative is when you test negative, but you actually have the disease. These 2 outcomes are influenced mainly by 2 things as well: the test itself, and the prevalence of the disease in the community. What are the chances of one getting a false positive test, for instance? Pretty low, 0 to 5%. That's because of the tests themselves and the fact that COVID is all over the place. What are the chances of getting a false negative for any of us? Pretty high. For the antigen or rapid test, it could be as high as 50%. For the PCR, it could be as high as 30%. Again, because of the tests themselves and the high prevalence of the disease in the country or community. That's why on the workplace, you will hear some people ask, before you can go to work, you need 2 negative tests 24 hours apart. Now, say, for example, you test positive, what do? You isolate for 10 days, and you have to be symptom-free for a day. Used to be 3. If you do that, and you're symptom-free without any use of any symptom relieving medications, you are now declared recovered and non-infectious. If, however, you remain symptomatic, you have to monitor yourself. By this time, everybody should have a thermometer, monitor it at least twice a day. A lot of people buy pulse oximeter. These are devices that you can clip on your finger. It shines a light on your nail bed and gives you a percentage of oxygenation in your blood. Normally, it should be between 96 to 100%. More importantly, though, you should monitor the cardinal signs of deteriorating clinical condition. Troubled breathing. The difference between shortness of breath and troubled breathing is even at rest, you're having a hard time breathing. It's also usually associated with a heavier cough and chest pain. If you're having these, it's time to go to the ER. Mental status changes. If you're confused, if you're having problems being alert or you're having problems staying awake, time to go to the ER. Skin changes. If you're turning pale, your lips, your fingers, your nail beds are turning blue, also time to go to the ER. If, however, you're lucky enough to be one of the more than 85% who manifest mild to moderate symptoms, there is one thing that's available now that's been approved by the FDA on an emergency use authorization basis. These are monoclonal antibodies. One is made by the company Regeneron. It's a combination of casirivimab and indevimab. And the other medication is made by Eli Lilly, bamlanivimab. These are intravenous medications that can be given on an outpatient basis for mild to moderate disease. It has to be given, however, within 10 days of onset of symptoms or testing positive. Now, who qualifies? Oh, by the way, these are good drugs, not great, but they're good drugs. Why? Because what they do is they just really, in the end, prevent you from ending up in the hospital. It just prevents a mild to moderate case of COVID progressing into a moderate to severe stage, therefore preventing hospitalization. How to qualify? Anyone out here who's 65 or over, you develop symptoms, test positive, you can get this. Anybody who's in stage 2 obesity, BMI greater than 35, anyone with chronic kidney disease, diabetes, anybody with immunosuppressive disease like lupus or rheumatoid arthritis can qualify. Anybody receiving immunosuppressive treatment, if you're a transplant recipient or if you're on chemotherapy for cancer, you will qualify. Any one of us from 55 to 64 with cardiovascular disease, you have a stent in your heart, you've had a stroke, or you're having circulation problems in your legs. Chronic respiratory illnesses, if you have asthma, if you have chronic bronchitis, or if you have emphysema, or just plain hypertension in that age range, you will qualify. Now, what else can we offer on an outpatient basis? Pretty much that's it, unfortunately. If anyone has any questions regarding vitamin D, vitamin C, vitamin E, hydroxychloroquine, antidepressants, antiparasitics, antiplatelets, et cetera, we can all see you at the Q&A. Feel free to ask those questions. From here on, I will turn the program back to Ricky Rionda. But before I go, if you have any questions regarding other medications like remdesivir, convalescent plasma, and Actemra, fellow Yuli Magalan will include that in his talk. Thank you for having me. Have a good night, everyone.
Thank you. Thank you very much, Dr. Coronel. And once again, if you have any questions for Dr. Coronel, please use our chat room. Now, our next speaker tonight is Dr. Ulysses Magalang, Upsilonian Batch 76. Dr. Magalang is a professor of medicine with the Division of Pulmonary Critical Care and Sleep Medicine at the Ohio State University in Columbus, Ohio. Dr. Magalang is a graduate of the UP College of Medicine and finished his internship and residency at Mercy Hospital in Buffalo, New York, and his postdoctoral fellowship at the Hospital of the University of Pennsylvania in Philadelphia. Dr. Magalang is listed in Best Doctors of America in Pulmonary and Sleep Medicine from 2005 to the present, and in the Castle-Conley Top Doctors in Pulmonary Medicine from 2014 to the present. He is a permanent member of grant review panels at the U.S. National Institutes of Health. And here to talk about therapeutics and vaccines, please welcome Dr. Yuli Magalang.
Thank you, Ricky. Good evening. I was asked by the organizers to quickly review COVID-19 therapeutics and vaccines. So let me start with this graph. So this is Central Ohio, where I live. This graph shows our current state of COVID-19 hospitalizations in Central Ohio, with increasing almost vertical number of hospital admissions as shown by the blue line. The red line represents ICU admissions, while the green line is the number of patients on mechanical ventilators. These two lines, as you know, typically lag behind the number of admissions by about 2 to 3 weeks. And these numbers pretty much represent what's happening in most parts of the US. But in the words of Hal Borland, no winter lasts forever, no spring skips its turn. So we're all hopefully gonna get over this soon. So there are only 2 drugs that are currently approved for standard use and recommended by the National Institutes of Health for the treatment of COVID-19. They're remdesivir or Remi and dexamethasone or Dexa. I put an asterisk under Remi because the drug has not been shown to improve survival, although it has been reported to shorten the time to recovery in adults who are hospitalized from 15 to 10 days. Dexa, on the other hand, has been shown to improve survival, but only in those receiving mechanical ventilation. So if you're going to remember anything from this talk, this is, I think, the most important slide. As you know, there has been a proliferation of experts in the social media. I would suggest, however, that we rely on information that has been vetted by experts in these 2 websites listed in the slide. So for those in the healthcare profession, I suggest using the National Institutes of Health site, which actually regularly updates the COVID-19 treatment guidelines. And for those not in the medical profession, the CDC website offers very relevant information. If unfortunately you get COVID, what drugs you will get will depend on how sick you are. So for those who are not hospitalized, you don't require to be in the hospital, or even if you're hospitalized, but you don't require supplemental oxygen because your oxygen levels are good, there is actually no specific antiviral therapy that's recommended as routine. As Emmer has said, there are monoclonal antibodies that are being investigated and can be used under an EUA. The panel actually recommends against the use of DEXA because it can actually be harmful. And if you are in those categories, the high-risk categories that Emmer mentioned earlier, you're probably going to get, more than likely, you're going to get remdesivir or Remi. If you require supplemental oxygen in the hospital, more than likely you're going to get remdesivir, or in our hospital, you're going to get remdesivir plus dexamethasone. And for those who are really sick and unfortunately require mechanical ventilation or specialized treatment like extracorporeal membrane oxygenation, the only drug that's routinely suggested and has been shown actually to improve survival is dexamethasone. So therapies that are currently being studied, but at present considered to have insufficient data to be recommended for routine treatment are listed there. The first one is convalescent plasma and monoclonal antibodies. I place an asterisk on the convalescent plasma because last week there was an article in the New England Journal of Medicine, which was a randomized controlled trial that actually did not show benefit in those with severe COVID-19 pneumonia. However, we do not know whether that's true for those with early disease. Turning on now to vaccines. As you know, you probably heard that we need at least 60% of the population to be immune to establish herd immunity from COVID-19. Basically, all forms of immunization work using the same principle. When someone is injected with a vaccine, then their body produces an immune response in the same way it would following exposure to a virus, but actually without the person obviously getting the disease. And if the person comes in contact with a virus in the future, the body is able to make an immune response fast enough to prevent the person developing the disease. Thus, in order to better understand how current vaccines work and how they were developed, we need to know how COVID-19 enters into the body and how we develop the immune response. We're going to discuss this in a few minutes here. On the left side is an illustration of the SARS-CoV-2 virus, the virus that causes the COVID-19 disease. And what it is it's basically an RNA that's encapsulated with a lipid capsule. And then you have this so-called spike proteins on the outside. The coronavirus, as you know, enters the body through the nose, mouth, and eyes. The virus uses these spike proteins and actually latches onto a receptor of our cell called the ACE2 receptor. It then is able to enter the cell. It uses the cell's mechanism to replicate, and then the cell dies, and then the virus then is released into the circulation, which then elicits your immune response. So this is how the immune response works against the virus. Basically, it's a little bit complicated, but the bottom line is that you produce antibodies. There's also cytotoxic T cells. The antibodies prevent targets the spike proteins, and it prevents the virus from latching onto that ACE2 receptor in the cells, whereas the infected cells are eaten up by this cytotoxic T cells. And then you have this you develop long-lived memory cells called B and T cells that protects you we don't know how long the protection is, but we don't yet know how long this protection is, whether it's going to be long-lived or will last only a few months. So the conventional way of making vaccines is to use a weakened or inactivated virus. So that's how the flu vaccine is manufactured. It will not cause disease when injected, but will elicit the immune response. It takes a while for us to develop this virus because it typically is grown in tissue. Like, for example, in the case of the flu vaccine, it'll be actually eggs. So there's a couple of companies that are using this technique, Codagenics in New York and Sinovac Biotech in Beijing, but they haven't finished their clinical trials yet. So DNA or mRNA vaccines are the relatively easier to develop. They're the new drugs or new vaccines. This is actually the first time that these vaccines are going to be used in humans. To produce them, they're easy to make because to produce them, you only need to make the genetic material. So you only need to make the messenger RNA, and that's nowadays that's a relatively simple thing to do. As you know, if you remember your high school biology, your DNA carries the information to make the proteins. That's translated into your messenger RNA that goes into the cytosol and then makes your protein. In the case of mRNA vaccines, there's a message there. The message there is to make the spike proteins or the proteins that mimics the spike proteins of the virus. So if you're interested in science stories, this is actually a totally fascinating story. The first report of COVID-19, as you know, it was in December of 2019. Chinese scientists published the genome sequence of SARS-CoV-2 in late January of 2020. By February, scientists already published the virus, that the virus enters the human cells using the spike proteins. And by November, they have tested the vaccine in thousands of people. And so that's a truly, in terms of vaccine development, that's truly a remarkable story. So this is the mRNA vaccine. Basically, it's a strands of RNA that's encapsulated in the lipid nanoparticle. And people think that it's not the mRNA that gives you the side effects. It's actually the lipid nanoparticle. So it's translated in the cell. So if it's given in your arm, the muscle cells will translate this. And you then produce these spike proteins, the SARS-CoV-2 spike proteins, and that elicits the immune response and gives you the immunity. So as you know, there are two companies that are making the mRNA vaccines, Pfizer and Moderna. The Pfizer one has some logistical things to overcome in terms of deployment because it needs a -70 freezer, whereas the Moderna can be stored in a regular refrigerator freezer. And the projected costs are shown in the slide. You have to remember that mRNA vaccines do not contain the virus. And also, it will not change your DNA. So here's some of the reported side effects. At least these studies are not yet peer reviewed. They have not been published, although they've been released by the companies. And basically, I think the most important here is fever, which occurs in about 2%. So 2 in 1,000 people will have fever, but it can be as high as 39 or 40 degrees centigrade. And then you got a slew of side effects here that you get usually with the other vaccines. And this side effects usually last 24 hours. And this presents some some logistical hurdles. For example, if you're going to vaccinate the healthcare workers, right? You don't want to you don't want to give this to everyone, and then all of a sudden they're going to have fever, and they don't feel well. So there might be some way to take into account, although it all happens only in about 2% of cases. So finally, there are the so-called viral vectors vaccines. This is the Oxford vaccine. They're less expensive. They can be stored at normal temperature. And basically what it is, this is actually easier to make, apparently, compared to the mRNA vaccines. What you do, again, the target is the spike protein. In this case, you put a coronavirus spike gene in a weakened viral vector. So for example, in the case of the Oxford vaccine, it's actually a chimpanzee adenovirus, which then elicits your immune response. So this is my last slide. Thank God for the nerds. We need to thank those people who had paid attention in school, because at this time they are about to save our butts with the vaccines. I don't know if you heard this song. This is John LaJoy. I would encourage you to Google this song called Thank God for the Nerds, and I think you'll like it. Thank you.
Thank you. Thank you very much, Brad Yuli. If you have questions for Dr. Magalang, again, put it in our chat room. Also, our chat room is being monitored in real time, and our Q&A panelists are busy reading your questions and answering them. And unless you want to direct them to any of our speakers, and if you do, please indicate that by putting their names on your questions, and we will answer them during the Q&A. Our next presenter tonight is Attorney Rodolfo Inky Reyes, Upsilonian, batch 78. This is turning out to be a batch 78 party. Attorney Reyes is a member of the Philippine Red Cross Board of Governors and senior partner of the Gordon Reyes Viado and Blanco law offices. Attorney Reyes is also a member of the Compliance and Mediation Committee of the International Federation of Red Cross and Red Crescent Societies. Now, thank you, Brad Inky, for joining us. Allow me to commend and congratulate you and our Brad, Senator Dick Gordon, batch 68, for the great work you all are doing for the Red Cross, not only in this pandemic, but in responding to the many natural and man-made disasters that have visited our home country. Now the floor is yours, Attorney.
Thank you very much, Ricky. And for the brothers and the sisters in the United States, a pleasant good evening to you. And for those in the Philippines, good morning. I will request Brad Bong Wei-Chanko to share my slides, please. Thank you. So I was asked to speak on the response that the Philippine Red Cross has to COVID-19, and I can proudly say that the Philippine Red Cross is really at the forefront of the country's efforts, as you will see later, in addressing and trying to treat this dastardly disease. Next slide, please. What did we do? Well, first of all, we needed to really know the enemy, as we stated earlier, and the only way to do that is to know how to be able to detect the presence of the enemy, which is the virus, in people. So we started quickly because at the time when the virus was really spreading in the Philippines, which was February, March, we only had the RITM, or the Research Institute for Tropical Medicine, conducting tests. And their equipment was manually operated. So our Brad, Chairman Dick Gordon of the Red Cross, knew we had to purchase equipment that would be able to test quickly so that we can help prevent the spread of the disease. And I'm proud to say that since we were accredited by the DOH, the Department of Health, and the RITM, since April 14, 2020, we've already conducted a total of 1,357,794 tests. And we've also established 23 laboratories all over the country. Now, mind you, this equipment will not go to waste, because after the COVID pandemic, which we don't foresee will dissipate right away, this equipment can be tested to test other diseases like AIDS, malaria, and other infectious diseases. Next slide, please. You can see by this this chart that the Philippine Red Cross actually conducts 20 as of November 20. This was not yet updated, so you might wonder why this is the figures are less. But this is more or less our share in the entire testing milieu. 23% of all tests are all over the country are being conducted by the Philippine Red Cross. No. And RITM has only 6%. Again, it's only doing manual testing. And also, the reason why this is so is because our costs are very, very low compared to others. No? Right now, we are charging for tests done through PhilHealth 3,409 pesos per test. And for private tests where we do the swabbing ourselves, 3,800. Before it was 3,500 and 4,000. So we are the least expensive among all the facilities that are doing the testing. Next slide, please. Here you'll see where all our laboratories are located. The molecular laboratories sign there is hiding Pangasinan. No, that's Pangasinan. So we're all over the country, as you can see. And for now, these are the only labs that we will maintain. Initially, we were thinking of 21, but we have now 23. So there is also one in UP Los Baños, undertaken by our fraternity brad, Chancellor Dindo Sanchez, batch 84. So he's got a lab in Los Baños. We were going to work with him, but UP Los Baños decided to undertake it itself. So that's fine, no problem. Next slide, please. This is one of the services that we offer, convalescent plasma. No, because we have blood collecting units all over the country. We have been able to convince some COVID survivors to donate blood. So we've already dispensed 545 units of convalescent blood plasma to 463 patients since July 13, 2020. This started a little bit late because we still had to contact those who recovered. And those who that we administered this to, of the, 173 already recovered, 44 ongoing treatment, 118 unfortunately expired, and 128 are not disclosed for privacy issues. Next, we have established a call center. You can see our to some of you, your junior Brad, to me, my senior Brad, Dick Gordon. He's overseeing the operations of our call center, and we've attended to 64,050 COVID calls since March 19, 2020. So this is part of our contact tracing efforts as well, and also a response to emergency situations where people with really terrible symptoms can call us, and then we can either send an ambulance or in special cases do the testing in their homes. Next, please. By the way, that 1158 hotline, that's our second call center. We have another one, a 143 hotline, which stands for I Love You Red Cross, and that is really for disasters. We also acquired negative pressure ambulance units, 6, which has served 295 patients since April. As you know, as many of our medical practitioners would know, the negative pressure ambulances are equipped with special equipment to ensure that you're able to safely treat patients with infectious diseases. So what it does is it just expels the air after it's filtered, so that it will minimize the spread of the disease. Next, please. Also, we have undertaken the setting up of medical tents. These are medical isolation tents in 23 hospitals and 7 facilities, which have already catered to 11,416 patients. 139 tents have been deployed since March 17, 2020. So you can see how the tents are set up, no? We have modern equipment there, and all the safety protocols are observed by all our medical technicians. Next, please. Even before COVID, even before we started our testing capabilities, we distributed 719,982 face masks, 26,575 PPEs, and 402 cadaver bags. Unfortunately, this is when the country was really starting to get hit, and this was before we undertook, as I said, our response to COVID by purchasing this equipment and test kits. By the way, just to let you know, the equipment that we purchased, some of them were donated by corporate sponsors. So we are forever indebted to them for their partnership with the Red Cross to be able to undertake these activities. Next, please. We've also done some cash assistance and food distribution. These are for families whose members were isolated and could not work. Kasama na rin dito, we've also been able to include those who were affected by the recent spate of typhoons. So as you can see, we've provided 7,575 families with cash assistance since July 3. 16,882 families received food packs, and 240,526 individuals were served with hot meals. This was also in partnership with some of our partner national societies all over the world, those who are members of the International Federation of Red Cross and Red Crescent Societies. Next, please. We also provide psychosocial support for those who've lost their loved ones in this battle. We do have clinical psychologists working with us, and also other social workers who are trained in this field. And as you can see, we provided 37,615 individuals with this psychosocial first aid, 3,101 individuals we served, restoring family links for those who were separated from their families, and 2,600 locally stranded individuals assisted. These are the LSIs, the OFWs who came home, who could not go home immediately. If you had followed Philippine news several, maybe 2, 3 months ago, there were a lot of these Filipinos who could not go home because they were stranded because the airlines and the ocean liners refused to transport them for safety reasons as well. So some of them were sleeping on the streets. Some of them were ferreted to the Rizal Memorial Coliseum and in other places. Unfortunately, only rapid testing was done, and it was mentioned by Dr. Emmer earlier that rapid testing only had like a 50% chance of accuracy, and many of them who went home to the provinces were the cause of the spread of the disease. In fact, my in-laws own a hospital in Butuan City, and prior to the LSIs going home to Butuan, the rate of infection there was very low. And as soon as they started going home, it started increasing. So, these places are now dealing with their respective situations. Hopefully, they'll be able to address these issues. And I think there are less and less LSIs that are subjecting themselves merely to the rapid test, and more are undergoing RT-PCR tests. Next, please. And of course, we do a lot of water, sanitation, and hygiene kit distribution. We've distributed 58,452 hygiene kits, 4.3 million individuals we've reached with our hygiene promotion. Yun yung binanggit ni Dr. Emmer earlier, washing of hands. 2,447 hand washing facilities were installed. 8.9 million liters of water have been distributed, and 1,761 jerry cans also distributed. So far, this is what the Philippine Red Cross has been doing. I have to commend, and I'm not saying this just because he's an Upsilonian and my law partner, but I really have to commend our Brad chairman, Dick Gordon, for his vision and his resilience. The guy works almost 24 hours a day, and prior to his staff being infected in the Senate, he was always in the Red Cross. So thank you very much for giving me this opportunity to update you on what the Red Cross has been doing.
So, um, if you have any questions for Attorney Reyes, please use our chat room. Our last guest tonight is Mr. Ted Tesoro, Upsilonian. Ted is a frontliner in his own right as a sales and marketing professional with LBC Express, service, making sure remittances and balikbayan boxes are delivered to their recipients in the Philippines. Even in this pandemic, it provides a lifeline to our kababayans back home. Ted is here tonight to tell us about his own personal story as a COVID patient and survivor. So please welcome our broad Ted Tesoro. Good evening, Ted.
Good evening, Ricky.
Uh, I guess my first question to you would be if you want to share with us how you think you contracted the virus.
Yes, well, first, I'd like to thank you for inviting me for this webinar. Um, um, Everybody, good evening, good morning. I'm honored and humbled to be part of this panel alongside with distinguished fellows that preceded me. Of course, like most um, people that got sick, they didn't really know exactly how they got it. I guess at least towards, during the early part of the pandemic. Like myself, I didn't really know. I only found out months after, probably about 6 months, when I got back to work. This was in August, and I had to do some mail and send some boxes over to our different locations in the East Coast and the Midwest. And there's this Suke mail station that I go to. I won't mention the name for liability reasons. Um, and of course, there's nobody there. This is time when not a lot of people were going out, unlike now. And I chatted with the guy. He knows me because I go there frequently, and we have a corporate account with them. And the guy over the counter just mentioned to me casually and said that he got sick mid-February, and since COVID was not a big thing at the time, he was only diagnosed as having the common flu and was bedridden for about 4 days and recovered and went back to work on the fifth day. Now, mind you, he also mentioned that he's been taking um, tocilizumab or Actemra for years now for his arthritis, and that's why he was able to recover faster than most people ever did. Unknowingly, when he went back to work, he was very infectious. In fact, he also shared with me that after going back to work, that about 8 out of 10 of his colleagues got sick after he went back to work, and that about two people or two colleagues of his even passed away. Now, also, if you think the magnitude of this scenario, this is a hub. It's a main hub of a big, you know, logistics company, and they service the tri-state area, which is New York, New Jersey, and Connecticut. So just imagine that magnitude.
Thank you, Ted, for sharing that. But would you tell us how you felt in the beginning when you first got sick and how it progressed from mild to severe illness?
Right. Sure. Well, for me, it started really, really light. I didn't really know that I had it probably sometime when I got exposed to that sickness. Sometime I believe mid or early March. I remember getting really tired and sleepy right after work. When I get home, I just jump into bed and just sleep it off, and then wake up the next morning still having my clothes on from the day before, and not even having dinner. And I just chalk it off as having, just getting getting really busy with work. Um, I just started off like that, and then I had to drive down to Virginia to see my wife. And day after that, I just started feeling, very fatigued or weak. Started having joint pains, body aches, and that progressed for maybe a couple of days. And I even called the Department of Health, and told them that I wanted to get an appointment to do some testing, COVID testing, but I did not qualify for. There were three qualifications that you had to pass to be able to get that appointment, and I did not qualify because I didn't have fever and uh, uh, um, um, and cough. So the next day, when I did get a slight fever or temperature, I called back, and they said that they couldn't give me any more appointment only because, again, they ran out of testing kits at that time. So towards that, I think in the first 3 days when I started getting really sick, having fever and started coughing, I called my doctor, and my doctor told me just assume that you have it right now, unless able to get testing done. Just assume that you have it, and he prescribed me a Z pack, Advil for the pain, and at the time there was still able to uh, prescribe hydrochloroquine. Um, and I was also advised by my doctor to get zinc sulfate. But unfortunately, during that time in mid March, they were out of stock anywhere you go, CVS, Walgreens, Walmart, wherever, you couldn't find them anymore on the shelves or even online. So it was really hard to get those stuff. Um, and I just started having more chills, more fever towards in the afternoon and early evenings, and more coughing has progressed. Started having a hard time talking, and having uh, out of breath and some weakness towards the latter part of the first week, starting the second week. And I was already starting to social distance myself with my wife, and I was staying in the living room, and the bathroom was literally 10 steps from where I was staying. So imagine if you've never trained for a marathon or a 5K for that matter, and you just decided to go ahead and do a 5K the next morning, and you ran 5K and you're so out of breath. That's me just taking 5 steps, literally. So really out of breath, just panting, and I'm trying to even not cough or pigilin ko yung ubo ko, only because when I start coughing, I would probably just keep on coughing for about 30 seconds or more. And when I do that, I could not breathe at all. And that progressed towards, I guess, towards like second half or later half of 10th day to 11th day of me getting sick, and I started not being able to sleep only because um, I would literally just wake up gasping for air. There's this sensation of a thin film like phlegm or substance on my throat that as soon as I feel like going to sleep or dozing off, I just wake up because I couldn't even, you know, clear my throat and take and inhale. So uh, that's what happened to me towards the latter part of the second week. And towards the 13th and 14th day, I was not sleeping for about 3 days already. And I just kept telling myself, if I could just sleep 4 hours, 5 hours of sleep, I know I would get better. I'd turn a corner, but I just couldn't sleep at all. And then my pulse ox was giving me different readings. Sometimes it was in the high 90s, low 90s, sometimes in the low mid 80s, and I'd you know put it on again and try to get a better reading. Rub my finger on it and make my finger warmer and put it back in, and so I'd have a get a better reading until to a point that I was just really weak, and phlegm was just everywhere, and yeah, it was really hard.
Wow, must have been quite an ordeal, Ted. Would you remember what was the initial uh, treatment that you got and subsequent treatment that you received as your condition
Right.
progressed?
Well, absolutely. If memory serves me right, like I mentioned earlier, my doctor prescribed Advil for the pain, Z-Pack, and hydrochloroquine on the first week, and then he told me, it's gonna get worse before it gets better, but you should feel um, um, better after the ninth or 11th day. But come 9 or 10th day, I wasn't feeling any better, so I was prescribed another Z-Pack and hydrochloroquine. Again, this is the time when nobody knew better, and hydrochloroquine was something you could still prescribe at that time. Actually, when I got that last prescription, the next day, the FDA stopped emergency use for hydrochloroquine. So I did that, and eventually, when I got to the ICU on the 14th day, when I went to the hospital, I went to the ER. Doctor told me that I had pneumonia, and ARDS, or acute respiratory distress syndrome. And my chest X-ray was, I don't know, and they went. I went straight to the ICU. And when I was in the ICU, they started giving me liquid diet, and I just thought to myself, "Why are you giving me liquid diet?" And I asked them why, and they told me that they were actually preparing me for intubation just in case the treatment would not work. Because and that time, it really hit me and just made me realize how bad the situation I was in. And luckily for me, on my part, that the hospital that I went to was part of a trial drug testing, and they were able to give me Actemra. Uh, and within minutes after giving me the dose, I was just, flat out sleeping. Just fell asleep and woke up probably 4 o'clock in the morning or 5 o'clock in the morning, drenched in sweat, and the fever broke. They just kept monitoring me if my fever would go back, but my temperature just kept going down and going down. And then the next day, I was out of the ICU again. Luckily for me, I was out of the ICU, but spent a total of almost a week in the hospital because, again, I was still coughing and had all the symptoms of COVID-19. Um, just a note, I guess, if this happened to me while I was here in New Jersey, it would have probably been a different story because here in Jersey, all the hospital beds were full at capacity. Even if you had the chance to get in and get yourself in, most likely they don't have any oxygen to give you, and most definitely not enough ventilators to go around if you need it. When I was in Virginia, there was not much cases then at the time, so I was lucky in that sense.
Would you share with us, Ted, how it was while you're self-quarantining at home with your wife?
Yeah, well, there's a lot of bed rest for sure, and I was given uh, 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 we were just basically separated. She was staying upstairs because it was a loft type apartment. She was upstairs in our bedroom, and I was downstairs. And I had her turn on her ceiling fan on, so there was positive pressure coming from upstairs, and I had my uh, the bathroom's vent on, exhaust fan on, so that there's some sort of downward air pressure that's going on, so that at least not much of my germs are going up there. She would always put on gloves, the face mask when as soon as we got them. Actually, they were just those cloth masks that we were able to buy online.
Mhm.
I was not allowed to go to the kitchen, although I still went because I didn't really want to bother her. I was not allowed to go to the kitchen, touch stuff. I was, if I needed anything, she would just bring it over. We did not eat together. She would eat ahead of me, or me eat ahead of her, and yeah, that was really hard.
Must have been really tough.
Yeah.
Uh, would you care to share if you have any kind of lingering effects uh, after after lingering effects of the virus or treatment?
Well, right after when I was discharged from the hospital, I don't know if you guys would remember those images on TV, on the news, wherein toddlers, infants having sort of red rashes on skin, and they were itchy. had those as soon as I was out in the hospital. I started developing some red rashes on my arms, my limbs, and they were kind of itchy. Luckily, it was not as bad. Um, and uh, Eventually, I still had loose bowel movement for almost 7 months, and um, some labor breathing, climbing up the stairs. But then again, that's just me probably being out of shape, really.
Um, how about medical bills? Did the CARES Act provide any sort of financial relief? Um, or did you have to pay anything out of pocket? I'm sure it must have been very expensive, hospitalization, professional fees, and all of that. So if you care to share us how that how that went.
Yeah. Yes, that was actually one of my concerns when I went to the hospital. The financial burden of it all. I did get a financial statement or a statement of expenses from the hospital, and I quickly called them up and asked them about it, and they told me it was just a statement. It wasn't a bill, basically just describing the care that I got and how much it cost. And it actually, if from memory serves me right, I think um, it totaled about 27,000 altogether. But I think the insurance just paid for it all. I'm not quite sure. I never really paid anything. That the only thing that I paid was the radiologist that read my chest X-rays. I guess my chest X-rays were really bad to read, hard to read. That's why I had to pay $40 for it. And yeah, that was it. Now to say if it was the CARES Act or not, I'm not sure. But one thing I'm really grateful for that, definitely.
Well, thank you, Ted. If you have any closing words, uh, you're welcome to say something.
Okay. Well, again, I'd like to thank this opportunity for being able to share my experience. If it would help anybody out there, battle this virus even better, then I'm happy to help. I'd like to thank everybody that supported us, myself and my family, and all the prayers that you guys gave me to get me better. Thank you for my family, of course, my brothers and my friends, and most especially to my wife, who was been there through it all, helped me out, helped me through through this ordeal, and was there beside me. And again, thank you, everybody.
Thank you. Thank you very much, Ted. I'm sure your broads in the Upsilon were rooting for you and praying for you during your ordeal. Are very happy that you survived, and more power, Brad. Now, again, if you have any questions for Ted, please use our chat room. So, ladies and gentlemen, this concludes our presentations this evening, and we will now begin our question and answer segment. I would like to introduce to you our Q&A moderator, Mr. Mike San Juan, batch 83. Mike is a marketing specialist for MedSpac and has worked in the healthcare industry for more than 30 years. He holds a bachelor's in nursing and biology. Mike is a community activist and currently serves as the executive vice president of the Filipino American Chamber of Commerce in the DC area and vice president of the University of the Philippines Alumni Association of DC, Maryland, and Virginia. Turning it over to you now, Mike.
Thank you, Ricky. Tonight, I was given the honor and privilege to introduce the rest of the panelists for the question and answer forum. The first person I'm about to introduce is a member of the team that developed the disaster program of the Department of Health of the Republic of the Philippines, otherwise known as the Stop Death Program. He established a trauma fellowship program and the emergency medicine residency program in the University of the Philippines. He became the regional coordinator of the hospital preparedness for emergencies, otherwise known as the HOPE program for Asia with Johns Hopkins School of Public Health. He's also an international consultant in the field of emergency and trauma that includes Palau, Maldives, Malaysia, Pakistan, India, Bangladesh, Nepal, Vietnam, Tunisia, Thailand. Ladies and gentlemen, please help me welcome our special advisor for the National Task Force on COVID-19 Philippines, none other than Dr. Ted Herbosa.
Thank you very much, Mike. Thank you very much for that kind introduction.
Thank you. Next on the list is the alumnus of the University of the Philippines with a Bachelor's of Science degree in chemistry. He joined the Mid-Atlantic Permanente Medical Group because it is an advanced, innovative, and integrated medical group that has proven to make positive changes in the member's life. Being part of this practice gives him the opportunity to provide the best preventive and medical care for his patients. He is a member of the American Academy of Family Physicians. Let us all welcome the president of the Upsilon Mid-Atlantic chapter, Dr. Xavier Key.
Good evening, everyone. Thank you very much, Mike.
At this point, I would like to reiterate the rules that was mentioned earlier by Mr. Rionda. Please use the chat box for all your questions. Include the panelists whom you would like to answer your question. Before we start with the question and answer forum, I would like to remind everyone that we have 3 gift certificates courtesy of our major sponsor, LBC. The first question will be asked at the beginning of the question and answer, and the remaining questions at the end of the Q&A. And in the true form of being in service to the Filipino community in this time of crisis, you can sign up in the link we will provide in the chat box to receive an LBC discount, coupons for $10 off sea cargo, 10% off air cargo, and money remittance to send to your family and loved ones back home. The mechanics of the raffle. After each question, participants can then answer in the chat box. First person to get the correct answer wins 1 free sea cargo, large box gift certificate worth $100 to send anywhere in the Philippines. The format would be you have to indicate your name, your email address, and your answer. We will announce all the winners at the end of the program. Question number 1. Which Balikbayan service company on its 70th year brings smiles to your home through its sea and air cargo, Balikbayan boxes, and money remittances? Please use the chat box for your answers. Mr. Ted Tesoro will be monitoring our chat box. He will notify us the winners. Again, the winners will all be announced at the end of the program. We have a lot of questions. Panelists, let's all start. Attorney Reyes, this question is for you. Much has been said about COVID for air travel. Is COVID testing mandatory whether you travel by land or by sea?
It depends on your destination. Some local governments will require you to get tested before you visit. For instance, I spent my birthday in Palawan and I was requested by the resort or required by the resort to get tested. So I got tested 2 days before. But overall, traveling to and fro, local governments, especially those which are situated close to each other, they don't require that anymore. Now, traveling to the Philippines is different. They've opened it already to Filipinos and even foreigners with Filipino spouses and children, and you will have to get tested. And the way to do that is to log into the Philippine Red Cross website, schedule a testing, include your details, your flight details and all, and then they'll give you a barcode. And then when you arrive in the Philippines, you will get tested. You'll be given another barcode to retrieve your results. Results can come in 24 to 48 hours. But if you're an Upsilonian or Sigma Deltan, just text me. And uutusan ko lang yung junior brad natin, si Josh Jimenez, batch 2015, who is the EA of Dick Gordon 68, and we will have your results in less than 24 hours. So just let us know. We can accommodate even friends. Nirarush lang namin. Except that sometimes when the test results are tested in the port area, that's where most of the OFW tests are done, and they're done by batches. So hopefully if you get tested, let me know right away so we can have it tested in our headquarters in Mandaluyong.
Thank you, Attorney Reyes. The next question is for Dr. Ted Herbosa. What would you consider your biggest challenge as an special advisor for the COVID-19 National Task Force?
Yeah. Thank you, Mike. First of all, let me say hello to all the Brads. Good evening to all the Upsilonians out there in North America. And of course, my other Brads who are here. Proud to be of Batch 78, currently represented very well here by two of the speakers. Very important question really is looking at the health system. We looked at when you look at a disease or the epidemiologic nature of disease, there are three things that you balance: the host, the agent, and the environment. So in the Philippines, when you look at it from the context of the Philippines, the most difficult part is looking at the capacity of the health system. I think the description of the virus and how it infects people were given by Emmer, and then the health system and the treatment facilities were given by how to fight the virus was given by Yuli, my classmate in med school in class 83, and my double Brad with the medical fraternity. And the third one is really the health system. And this is where the Philippines is a bit different from the rest because, for example, our hospital to bed population ratio is a measly 1.5 hospital beds per 1,000. And the US is something like 4.7 beds per 1,000 population. So that's the difficulty when you have a pandemic. In a pandemic, the difficulty is allocating resources, and you saw this in the different states that had a high number of cases, wherein there was lack of health human resource and ICU beds that were critical to admit the critically ill patients, which would affect their mortality or outcome or health outcome. So in the Philippines, our best bed to population ratio is actually only in Metro Manila, Metro Cebu, and Metro Davao. All other provinces are really, to my category, third world. And that makes us scarier. So that was the most difficult, making sure that the inoculation of the virus didn't spread to the other regions of the part. And that's where we implemented very strict lockdowns. The hard part about the lockdown was that it affected the Philippine economy. Because, for example, when we locked down Metro Manila and we're one of the longest lockdowns, we're going to be in GCQ until December 31. 25% of the Philippines' GDP happens in metropolitan Manila, and the other large proportion is actually in metropolitan Cebu. So you can imagine how much our GDP went down. We went down to negative 16 from a high prior to 2020 to a high of about 6% GDP annually. So we're now at negative. So now the healing process in the Philippines is about recovering the economy because our numbers are now low. 2 days ago, they were reporting less than 1,000 cases a day. And we've never had that low numbers since July, since 5 months ago. But the scary part is we're now opening up for Christmas. So I hope that the people will continue to believe in the minimum public health standards, wear the face mask, observe social distancing, wash their hands, and we do hope to fight this virus with uh, public health measures as well and self-discipline. Thank you, Mike.
Thank you. Thank you, Dr. Herbosa. Next question is for Dr. Xavier Key. What is the difference between PCR testing and rapid testing? Dr. Key, please unmute yourself.
Yeah, sorry about that. Thank you, Mike. So again, both PCR and antigen tests are both diagnostic tests, which means that they could be used to determine whether you are currently having an active coronavirus infection. The difference is the PCR test detects the presence of the virus genetic material using the technique of the reverse transcriptase polymerase chain reaction, or the RT-PCR. Commonly we would collect samples through the nose or a throat swab, or saliva. Generally speaking, the PCR is very highly accurate. However, one of its problem is it could take days or over a week or hours to get the results of the PCR test. In comparison to the antigen test, which detects specific proteins on the surface of the coronavirus, uh, this is a lot faster test. That's why it's called the rapid diagnostic test. Most of the time, you could have the results in less than an hour. The problem with this is that, let's say, if you test positive, you're surely positive. But if you test negative, then there is a question if you are really negative. So most of the time, doctors would ask for a confirmatory test, which is the PCR. I just want to let the people think the antigen test or the rapid test as the rapid strep test or the rapid flu test. A positive result for any of the tests is likely to be accurate and allows the diagnosis of the strep throat or flu. However, a negative result often results in further testing to confirm or overturn the initial results. So, in Tagalog, hindi siya ganun ka-accurate like what the speakers have said.
Okay. Thank you, Dr. Key. The next question came from Bobby Hoxon, batch 77. This is addressed to Dr. Magalang. How long is the vaccine effective for? Will a booster shot be required? Dr. Magalang?
Thank you. Yep. Can you hear me?
Yes, you're
Okay.
loud and clear.
So if you're talking about the mRNA vaccines, which is probably what we're gonna get first, which is I'm talking about the Moderna and the Pfizer. So those two vaccines are given in two separate doses, right? So you get the first dose, and then you get the second dose 3 weeks later. How long the vaccine is going to be effective is not really clear at the present time. However, if you look at the data on people who had COVID-19 and developed immunity, so people have studied them and brought them back and did blood work. They found neutralizing antibodies to COVID-19 as long as about 6 months. The question is, if you have antibodies, that doesn't mean that you're immune. So for example, there's a question from one of our docs when we had one of our meetings. Hey, what if you had the symptoms of COVID-19 or you had COVID-19, will you still get the vaccine? And the answer is a big yes, because we don't know whether even if you have the antibody, that you're actually going to prevent disease.
Okay, thank you, Dr. Magalang.
But
Next
if
question.
I have to guess, I think it's going to last 6 months and probably longer. Whether you're going to get a booster, you're going to require a booster is not clear at the present time. And honestly, I don't care. I just want to get out of this mess, that we are in. I want to be able to go home. I'm going to grab the first vaccine that I could get, because the unfortunate instance that I get infected, I don't want to have the severe disease, and I don't want to have my family to have the severe disease. And I'm tired of sleeping on the weekends when you can get called in the hospital because they need more docs.
Thank you, Dr. Magalang. The next question is addressed to Dr. Coronel. You specified in your talk earlier, Regeneron should be given 10 days from the onset of symptoms or once you were tested positive. What happens when it is erroneously given beyond 10 days? Dr. Coronel, please unmute yourself.
Yes. Thank you for the question. There is no, well, the effectiveness, the idea of the monoclonal antibodies being given at that time is to prevent you from getting the severe disease. The study shows that if it's given in that time period that I mentioned, that it will do the job. If it's given beyond that, it doesn't do the job. So if it gets given to you, if you're worried about side effect profile, it would be similar. But if it will be effective in doing what it's supposed to do in preventing hospitalization, we have no clear answer to that. But again, it probably won't hurt if you do get it in terms of minimizing the progression of your disease, because everybody gets sick of this in different ways. Some individuals will recover in 3 days. Some individuals who suffers from long COVID can have it for months.
Okay.
The
Thank
answer
you,
is
Dr. Coronel.
yeah.
I'm just going to add something, if you don't mind, Mike.
Sure, go ahead,
So,
Dr.
so we're
Magala. Go
talking
ahead.
about monoclonal antibodies, right?
Yes.
Yes.
The BAMLA. Okay. One of my colleagues said, "Oh, it's that drug is difficult to pronounce and even difficult to give." So remember, as Emmer said, it's given intravenously, and it's not like you're going to give it intravenously and you go home. It's a protein, so you can get allergic reactions. So you're going to have to be watched for at least an hour or a couple of hours. So the infusion lasts about an hour, and then you're going to be watched for about 2 hours. So it's going to be a 2-hour ordeal for an outpatient medication. And honestly, the randomized controlled trials are not a very, I would say, it's approved for EUA, but it's not well established whether it truly will prevent hospitalization. Hence, the NIH does not recommend it as a routine, but could be given for the high-risk people.
Thank you, Dr. Magala. Now, this
Exactly.
question is,
And if I may add, in addition, they have to follow up with their primary caregiver or whoever gave it a day or two later to make sure that these side effects don't happen.
okay. Thank you. Noted, Dr. Coronel. Now, this question is for Dr. Key. What, with the ongoing new tests, such as the saliva test, how does it compare with the traditional PCR and rapid tests in terms of turnaround time for the results and accuracy?
Actually, the saliva test is just another source of specimen where you could test the person, like getting a nasopharyngeal swab. It still mainly uses the PCR test. The main advantage of this is that, these people don't have to be they don't have to go to a healthcare professional, which would save a lot of time, a lot of PPEs, and which has been in short of supply. So depending who's providing or doing the test, I mean, the turnaround time would just be like any PCR test, 24 to 36 hours, the fastest. And again, that doesn't include if they have to mail the test to the providers.
Thank you, Dr. Key. This one is for Dr. Coronel and Dr. Key. How are primary care physicians responding to the rising number of COVID cases? Dr. Cornell, why don't you go ahead and start?
All right,
Answer
thank
the
you.
question. Yeah.
Well, I'm not sure if you meant that on a personal basis or treat patients, but
Okay.
personally, I would just reiterate what Brad Yulee said. I mean, it's been a strain for a lot of providers because it's been for so long, and it's beginning to affect morale and performance. But I'd like to say we're still up to task, and we'll keep on going and chugging along. Regarding response to our patients, we just have to keep up to date with what's latest and what works, and more importantly, what is safe. I tend to be conservative with my treatment. For example, since the Eli Lilly and the Regeneron products have received their EUAs. I've only referred one patient who was really in danger of being hospitalized because the patient was very high risk, type 1 diabetic on dialysis, and was super obese. And I believe he did still ended up in the hospital, but survived. We won't know the total outcomes until we gather all the data. I did say these medications are probably good drugs, but not great. But it's the only one we have. So.
Thank you, Dr. Cornell. Xavier, I know you, Kaiser has a different approach with the rising number of cases. Go ahead, Xavier. Dr. T.
Yes. We do use technology to our advantage. Since we all know the healthcare system is getting swamped, so we could use video technology to see the patient, accurately triage them, and send them for testing if possible. And for those with mild to moderate symptoms that could be treated at home, we follow them up through video every day. We do sometimes send them free oxygen saturation machines so they could monitor their oxygen. We also send them oxygen if needed. So right now, the most important thing for people who are may or may not have the disease is access to healthcare providers so that they could be triaged properly and treated properly. And technology is always gonna be a big role player in this.
Okay. Thank you,
Mike?
Dr. T. Yes.
Mike, it's Yuli.
Yes. Yes.
So may I just kindly tell you how hospitals for inpatients are coping, right? So usually if you're in the hospital and you get admitted with COVID, you get to a service that's run by so-called hospitalists, because they're the experts on hospitalized physicians. Nowadays, if in some areas of the country, you can get a rheumatologist or a GI doctor who's not done internal medicine taking care of you in the hospital.
Okay. Thank you.
That is true. In addition to Dr. Magalang's comment, we are utilizing other other specialists. Like sometimes an orthosurgeon could check on the patient, see how the patient is doing. This was most commonly seen during the first wave. Even primary care doctors like me, who are mainly office doctors, were being retrained to do ICU stuff. So, so this is how the healthcare system here in the U.S. is responding. All the other specialists who don't see medical cases are trying to pitch in to help the frontliners, the hospitalists, especially.
Okay.
Mike,
Yeah.
Thank you, Doc.
Yeah, in
Mike,
addition, in the state of Maryland, our governor fast-tracked nurses to graduate early, a year early, providing they comply with the barest minimum so they can be activated. This is really like war. We are in dire need of staff. Hospital beds are actually a little more available. The problem is staff. So with that in mind, to all those who are listening, anybody who still fears this vaccine, please ask your questions. It would be nice if everybody who listens tonight, by the end of this panel discussion, that you will all be open to the idea of getting this vaccine. I get it. Nobody wants to get this disease. That's why I want to be vaccinated. But we're in America, right? We tend to think more individually. But in any vaccination program, it's not about me getting the disease. It's about the population getting rid of the pandemic. So actually, you do not vaccinate a person, you vaccinate a population. And that will only happen if every one of us get on board.
Thank
Now,
you, Dr. Cornell.
Will there be GBS down the road? Will there be all these long-term side effects of vaccine? Of course there will be. There will. Millions would be vaccinated. But think of the hundreds of thousands of lives that would be saved. I mean, I drive more than once a day. When I get out there, there's a 1 in 27,000 chance something can happen to me. The chances of getting something from this vaccine, long-term and permanent, is like winning the lottery, in my opinion. I don't know if Brad really agrees with me, but side effects will happen, as he said. That just means the vaccine is working.
Okay.
Thank you.
Thank you, Dr. Cornell. I'd like to remind everyone to please use your chat box for your question. Dr. Xavier Key is helping me in monitoring all those questions. The, the next question is for Dr. Magalang. How safe are the vaccines for administration, considering that the development and testing were a lot shorter and faster than the usual research?
So we know that the two vaccines, for example, right, the mRNA vaccines, we know that each of those were given in more than 40,000 patients, and they've been monitored for the side effects. So these are studies that are well conducted. And the other thing to remember is the technique of developing mRNA vaccines did not start in 2020. It started long before 2020. It's just that this pandemic provided an opportunity to get a simple vaccine that could be manufactured from synthetic mRNA. So to answer the question, the bottom line is it is safe. There are side effects, but remember the side effect. I think the most important side effect probably is the fever, but it occurs in 2% of people who are vaccinated. You have to remember the vaccine in general kills 1 in 200 people. 2% is 2 in 1,000, and it will last 24 hours. So I think the risk-benefit ratio is very apparent, at least in my mind.
Thank you. Thank you, Dr. Magalang. A follow-up question for you, Dr. Magalang, since you're becoming very popular. Based on your expertise and knowledge among the COVID vaccines, which one would you highly recommend?
Okay. So since this is a global audience, my recommendation is to get the first vaccine that your government will get from those 3 vaccines that have been tested adequately. So I know where this question is leading to. So for example, there are reports in social media that the Pfizer vaccine and the Moderna vaccine do not prevent infection, whereas the Oxford vaccine will prevent infection. But to understand that, we got to understand and differentiate infection from disease, right? So, and how this vaccine were tested. So for example, infection means that you get the virus and the virus is replicating in your cells. So in your nose and in your mouth, right? Disease means that the cells are damaged and that you're getting the symptoms. Now, what they did in the mRNA vaccines, which is the Pfizer and the Moderna vaccine, is they gave it to more than 40,000 people. Half got placebo and half got the real vaccine. And then they tested for the occurrence of disease, meaning they will only test you if you have symptoms. You can't possibly test and get PCR tests on 40,000 people. It's just not possible to do that within that context. So they're able to say that the vaccine will prevent disease. And honestly, that's all I need. We don't know whether the vaccine will prevent infection or transmission. We don't know that. But what we know, if you get the vaccine, chances are, if you get infected, you're not going to get severe disease. And right now, that's all I need. Now, the other vaccine, the Oxford vaccine, did it differently because they tested only 12,000 people. And so what they're able to do, they did actually PCR tests in asymptomatic people. And so they're able to see, although the data is not in yet, whether it will be able to prevent infection and disease, because then they tested also the symptomatic people. And so, but there are also problems. The Oxford vaccine is very, very problematic. As you know, they goof up the dose. The manufacturer made a mistake, which the company admitted that they made a mistake, and about of those 12,000 patients, 3,000 got a lower first dose, half the dose, and then the second dose was the full dose. The other 9,000 got both the full dose, 3 weeks, 1 and 3 weeks later, after the baseline dose. So it turned out that those people, the smaller number of people, the effectiveness of the vaccine to prevent disease is 62%, whereas it was 90% in the lower, where they get the lower dose. But the 2 full doses, it was only 62%. So then they reported that it was the total effectiveness is 70%. But again, these are media reports. These things have not been published. But I can tell you, I have a feeling the Oxford vaccine is gonna have a hard time getting an FDA approval. But I don't know. I don't know if that's going to be true. But there are problems.
Thank you, Dr. Magalang. Ricky, I just wanted to find out, how are we doing with time? Can you give me an update, Ricky? Okay. So, Xavier, if you could help me out with, all these questions on the chat box. Next question I got is for Dr. Coronel. This is from Danny Senseng, batch 76. Dr. Coronel, will insurance cover the antibody treatments?
Oh, yes. Hi, Danny. Hi, Brad. Kamusta? Good question. So the monoclonal antibodies had their EUAs, the bamlanivimab early November, and the Regeneron 3 weeks later. Once they had the EUA, Medicare covered it under the COVID-19 Act. Now, it's important though that to understand how this is being distributed. It's by state, right? So the state mandates how it's distributed. But if you do get it, and either from your primary care physician, or you tested positive after an urgent care visit or ER visit, and you were sent home and you qualify with the criteria, and if you have Medicare, and as Medicare goes, all the other insurance goes, what could help you is, and Medicare does cover it, right? What could help you is know the codes. You may wanna, if you have the Eli Lilly product, the bamlanivimab, the code for the doctors out there, or even if you're a participant. I've had patients of mine tell me, please doctor, code it this way. It's M0239 for the bamlanivimab, and it's M0243 for the Regeneron. If we put those codes in, Medicare will definitely cover it. That covers for the infusion, the monitor, and the follow-up visit. Hope that answers the question.
Thank you. Thank you, Dr. Cornell. This question is from one of our panelists, from Dr. Ted Herbosa. This is addressed to Dr. Key. Is Avigan available in the United States?
I think I answered that in the chat box. It's still
Right,
mainly available.
For the benefit of the other attendees.
Yeah, it's still mainly available for just for studies and not yet available to the public or for treatment.
Okay.
So going there, Mike, I think Junjun Villar has a question for Dr. Herbosa. Dr.
Go ahead.
Herbosa, is it true that the Chinese and Russian vaccines will be given in the Philippines? How safe and
That's
effective are they?
okay. That's correct. In the Philippines, the vaccine strategy is a portfolio strategy. We have a vaccine expert group that's looking at 8 candidate vaccines. These are 8 of the global vaccines that have gone to phase 3. And this includes, of course, Pfizer, Moderna, AstraZeneca, and of course the Sinovac, Sinopharm, the 2 Chinese vaccine. I think Janssen, Johnson and Johnson, and I think there was an Indian vaccine also included in the portfolio. So the vaccine experts are looking at the results. Their procurements are different. For the AstraZeneca, we've actually pre-procured about 2 million doses, 1 million for the private sector, 1 million doses for the public sector. So that's the first procurement that's been done. So it's pre-ordered. The AstraZeneca promises to deliver it in the middle of 2021. The others, Sinovac and the Sinopharm are entering to a government-to-government deal. So it's a G2G. If they are able to pass the FDA of the Philippines based on the phase 3 result trials they deliver, then the government will procure it through a government-to-government procurement. The Pfizer and Moderna, Pfizer has a logistical problem for the Philippines because Pfizer requires a minus 70 degrees storage and transport. And that becomes a nightmare. You think about the Philippine Islands where you have to fly the vaccines from Metro Manila to the other. So the strategy for Pfizer, if indeed we get Pfizer BioNTech vaccine, is to actually use it for the metropolitan cities. That means using Pfizer for Metro Manila, where minus 70 freezers will be available and can be stored and be given to people. So it's going to be hospital-based in terms of distribution, whereas the others, the AstraZeneca is actually available on the regular freezer 4-degree vaccine that can be delivered all over the country through our existing cold chain. So this is the strategy. I beg to differ with my classmate Yuli on this matter on get the first vaccine. I will wait. I've had the COVID-19 as an asymptomatic patient, and I was given Avigan. That's why I asked about Avigan, which is an antiviral, anti-influenza drug from Japan. It's also being used on experimental trial. But I'm on the opposite track because I agree with my kabatch Emmer that what you need for vaccination is not the vaccine, but the vaccination program. And a vaccination program is supposed to attain a certain level of herd immunity. That's how you fight the pandemic. The problem is you don't acquire herd immunity in a day, in a week, in a month. You probably acquire it over 2 or 3 years by probably injecting the high-risk population. Then you develop with a certain level of people getting infected, getting natural immunity, and another high-risk group being given the vaccines that do work and give them immunity. That's the time you'll reach a certain level of what we call herd immunity, and then you break the pandemic or the epidemic transmission. But individually, it will provide protection as Yuli wants it. Its purpose is to get it because he works in the hospital, so he gets protected. So that's one purpose of getting vaccinated. The other purpose you want to vaccinate is to attain herd immunity. The problem, because it takes that long, in the Philippines, we've achieved a certain level of decrease in transmission. We're now at, I think, 0.8 in terms of our reproductive number. And it's all on public health measures, universal mask wearing, all this disallowance of mass gathering events, etc. So I truly believe that prevention and public health measures do work as good as the vaccines. And we need not to forget that. We need to continue that, especially for low and middle income countries. We need to concentrate on maintaining. And even Fauci has said this. Even if we get the vaccine, people still have to wear the mask. People still have to physical distance. People still have to wear masks and take the necessary precautions. So don't forget the minimum public health standards is the one that will break this transmission. Thank you.
Thank you, Dr. Bosa. We need to wrap up in 20 minutes. We have a lot of questions still. So This question is for Dr. Emer Coronel. What is the most common misconception about COVID-19, the coronavirus?
Okay, the most common misconception about the coronavirus. The most common misconception is that it doesn't exist, but it's not true. Let me explain more about the coronavirus briefly now. The truth is, if an average person gets it, you'll probably be going to be okay, and that's true. The issue is with the case number being the way it is. That's a measure in the best we can do in real time how this thing is progressing. So it is real, and that's the way we can monitor it now. The conception that it's really, I'm going to be careful. I don't want to sound that I'm being cavalier about this, but the case fatality rate on average in the United States with 14 million dead and 14 million cases and 300,000 dead is about 2%. Actually, it's getting lower. The rate of hospitalization per number of cases, let me be clear on that, is actually getting lower. So in a sense, okay, and I underline that, in a sense, it's not that bad. The reason it's really bad is because of the number of deaths. And Lord knows how many chronic conditions that will arise months after. So that's, in my opinion, what this pandemic is all about. In the end, I did say earlier in my talk that chances are one or two of your extended family will test positive. And that's true. But it's also true that chances are they will be okay, no matter if they qualify for the monoclonal antibodies. Most of the time, you will stay at home, follow the rules, and everything will be okay, most of the time.
Okay, thank you, Dr. Cornell. Now, the next question is for Attorney Inky Reyes. There's a lot of talks and controversy about PhilHealth. Can you care to comment on this?
Well, actually, I also prepared slides for that, but let's not go there anymore. Just to let you, charity organization, we are not charity. We are charity for those who really can't afford, the very poor. But first of all, the government was the one that approached us. As early as April, we had our machines automated at that because Brad Dick said that we cannot do with the manually operated machines that RITM has, no? And we needed the automated machines to make the testing faster, to get the results faster. Again, part of our prevention efforts, no? We needed to detect how many people had COVID. So it was DOH and RITM who approached us, and PhilHealth, to please service the referrals of PhilHealth. And so we entered into a mall with them on May 5. Now, Dick, coming from government, knows that it takes so long, and I'm sure Teddy will agree with me, and those of you who've worked with government, it takes so long for government to pay. So Dick asked for what you may call a revolving fund, and we termed it an advance payment. Now, the revolving fund was supposed to be replenished every so often because we have to get test kits from China. No, we bought machines from China, from Sanshore, and the test kits that they produce are very, very well, for want of a better term, they can be used by the machines. No, the other test kits we were not sure, so we had to buy from China as well, and we had to import. And every time we use test kits for testing, of course we have to replenish our stock, no, and we needed to be able to fund all the purchase of the test kits. And not only that, we needed to maintain our machines. We were spending 35,000 per med tech. We hired around 130 for the entire country. We didn't want to pay them cheap because otherwise they will leave us. So this controversy with PhilHealth is they just weren't paying what they were supposed to be paying, and at one time the PhilHealth debt reached 1 billion pesos. No, the overdue balance plus their current balance. To this day, they owe us 623 million pesos. And again, I just revised a demand letter warning them that if they don't pay, we will again stop our services. Now, let me just tell you the impact that the red the cessation of our services has on the Philippines. No? When we stopped testing on October 15, the national testing output dropped to 18,832 tests per day compared to 34,000 tests per day. That was the lowest since July 12, no? And the test output in the National Capital Region dropped by 80% because we started limiting our testing only to non-PhilHealth referred tests, which is really the private sector. On the average, national testing output dropped by 17% or 6,000 tests less than when the Red Cross accommodated testing charged under PhilHealth. More than 6,000 returning Filipinos were stranded because of the delayed release of testing. The hotels got really full because, when Red Cross tests, yes, 24 to 48 hours, sometimes earlier, no, the hotels can now release their guests and the guests can go home, no. If you're negative, there's no need for a 14-day quarantine, although it is advised that you still quarantine yourself. But there's really no need. Government and individuals paid more because of extended stays in hotels due to delayed release of results. And this is what was killing the public. Private labs were charging exorbitant amounts. We found out in the airport that these private groups were charging 7,000, 10,000, and even one charged 20,000 for the immediate release of results. So that's what happened. No? Compared to what the Red Cross charges, we were charging OFWs and PhilHealth referred cases only 3,500. And when we do the swabbing, we charged 4,000. So really, there were comments that Dick Gordon and the Red Cross mukhang pera. I wish that they would make those comments when we're unable to pay AstraZeneca. If AstraZeneca bills us and then we can't pay their bills, no? Unfortunately, these people don't really understand what they're saying. But we're getting through. We're still fighting. We're still there, and we will provide services for as long as we're needed. And the very poor, we provide services to them for free. Even our blood is free. So the PhilHealth issue is just a question of them paying their obligations. As you know, PhilHealth was embroiled in so many issues of corruption that date back even when my kabatch Teddy Herboso was still Undersecretary of Health. He already warned us about the corruption of PhilHealth and another drug that was very controversial here, no? And so Teddy knows what's going on. So it's really sad. It's really sad that the Red Cross is being made to look like a villain when we are the ones that are really going all out to help the public. So that's where that is really basically the issues involving PhilHealth revolve around. Thank you.
Thank you, Attorney Reyes. We have 5 more questions before we wrap up. A question from my kabatch, Benji Abad Santos. Is that vaccine safe for immunocompromised individual? This question is addressed to Dr. Magalang. Dr. Magalang?
Sorry about that. The vaccines will actually, the mRNA vaccines will actually be great for immunocompromised patients, although we do not know exactly how effective they would be because we do not have the full report out of those 40,000 patients, how many are actually immunocompromised. However, remember the mRNA vaccines do not contain any viral material. So that's, and it's not, it does not have the virus, and it will not affect your DNA. So they're actually they're great vaccines for immunocompromised people.
Okay. Thank you, Dr. Magalang. Second question for Dr. Bosa. What do you think would the United States learn from the Philippines as far as mitigating and containing the virus?
I have something to share regarding this.
Okay, let's hear
Is
it.
it Sari? Start from. Because the Philippines in March developed what is called the National Action Plan. So I'm supposed to be sharing it here. Is it showing?
Yes,
I'm not seeing it. Anyway,
I'm seeing it. So does
are you
everybody
seeing?
see it stopped? Yeah, you stopped
I'm sorry.
sharing,
So
Dr. Bosa.
let me share
Go
that
ahead.
again. So I'm sharing the National
We can
Action
we can
Plan.
see it, Doctor.
Broadcast. So this is the National Action Plan, which we patterned after the Korean model. The Korean model is test, trace, and treat. And we saw at that time in March, this was one of the best countries that actually curbed the virus very quickly. So our problem at that time in the beginning was that we didn't have PCR labs. We even had to send the first few samples to Australia. And that was what was built up in the first 3 months, March, April, and May. We increased from one laboratory in the Research Institute of Tropical Medicine all the way to 150 labs today. And as you heard from my kabatch Inky, 25% of those testing centers belong to the Philippine Red Cross all over the country. So they contribute really a fourth of all the test results. Then we also used our gene experts. This is a device that actually is able to, it's also a PCR, but it's automated, and it gets the result in about an hour or so. Now, we improved testing, and then we saw that our problem was contact tracing. Oh, by the way, with all this plan, we also implemented a universal mask policy. And you all know we have universal wearing of masks. I don't know, the Asians must be doing something better because we don't think as individually as the Americans. And that's where I think people should learn from the Asians. Japan, Korea, Taiwan, Hong Kong, Singapore, the Philippines all have a universal mask wearing policy where they wear masks. And this is part of your public health, that I care for the other person in the community not to get infected from me. So it's something like I'm protecting you. I'm not protecting myself when you wear a mask. So I was aghast to see that in America, the mask became very political. So I do hope that when Biden comes to office, he promised that he will issue a universal mask policy for 100 days. I think this will curb the virus. And I think we are at our very low numbers now because of this universal mask wearing, our testing, our contact tracing, and our isolation. So our total is about 400,000 cases so far, 7,000 deaths for 110 million Filipinos. So I'm actually very proud of that because we're not doing bad. When the opposition, the political opposition always labels the Philippines as the highest in Southeast Asia. Actually, we find out that Indonesia is actually much higher because they have very little testing capacity. So I think,
Bosa, Dr. Ted?
yes.
Okay. So I got a notification from one of our moderator to tell you that you are not sharing your screen, but just your phone screen. So
Oh, sorry.
just to let you know.
Let
Okay.
me I'm a problem. Okay. Let me just. Is it? Let me do that.
That you might be sharing the wrong application.
Yeah, I must show you the. Is it showing now?
Yep.
Yes. Thank you.
So this is our.
But remember, you're sharing your phone, so all your messenger messages
Yeah,
are
I know
showing.
it's coming
Yeah, we
out.
could see all those. Any special appointments and special deals, it's all there.
Anyway, just imagine I can share it on Viber, in the UPNSA Viber, but the National Action Plan really talks about the test, trace, and treat. And I've not heard of a National Action Plan from the United States, and I do hope that if ever Biden gets to office with the experts he put together, I'm sure they will put together a very robust National Action Plan. this is what the Philippines has. And I think other countries have actually looked at us. The British ambassador actually talked to us regarding our plan because he was so interested with how comprehensive the Philippine National Action Plan was. So there we are. We were able to control the virus, but we suffered our economic activity. So it really has a balance. I think that's about all I have to say about that.
Okay, thank you, Dr. Herbosa. Just to want to remind everyone, we are only, there are two more questions. From Evelyn Aliling, batch 69. Do we have, hold on, let me see. Xavier, you could help me with this. Do we have a data on percentage?
Okay, there's, I guess
Sorry, this one's
the
scrolling down.
question is
Go ahead.
to the panel, Dr. Coronel or Dr. Magalang. There was a question regarding reinfection in COVID. Do we have any new data or numbers about that? How prevalent is reinfection of the coronavirus?
One word,
Well,
rare.
go ahead.
I'm sorry. One word,
Go ahead.
rare. Go ahead, Julie. I didn't mean to interject.
I think the academic answer would be we don't know 100%, but it's more than likely that if you have the neutralizing antibodies and it's present for months, that you're probably going to be protected from COVID infection, or at least you're going to have not severe disease.
Yeah, just case reports, genetic studies. I saw one on the Lancet one time. It seems convincing. Reinfection of different strain 3 months after a very healthy, I think, 25-year-old Englishman. Well studied because they were able to actually get the the genome of the virus that he had both times. So again, we don't know, but unlikely, I agree. Now, if I moment, something just came to mind regarding the question that was asked to me earlier. Misconceptions. I think it's very important. Going back to nuts and bolts of this thing, you hear a lot about vitamin D and all these other medications, antidepressants, anti-parasitics, in terms of preventing or even treating COVID-19. Again, we have no data regarding the effectiveness of all these that you see on the internet, like what Brad Yuli said. But here's my thing about supplements. I'm not a big fan, but one thing I notice among my patients, the ones who are into supplements, they have one thing in common. They all want to be healthy and safe. So to me, it doesn't hurt. And you feel, I don't want to take the wind off their sails. And I just encourage them to be healthy. And if that's their part of their regimen and psyche to be able to combat this virus, it's perfectly fine. Now it's different if you want to get on board on hydroxychloroquine, antiplatelet aggregate medications, then that would be a red line there.
I just want to add, so there's actually an ongoing clinical trial of vitamin D supplementation, D as in David, in people who are vitamin D deficient to prevent COVID-19. That trial is out of Harvard, but we don't know. We do not know the results yet. It's very clear that we need, the BAMLA and all those things are intravenous. It's very clear that we need drugs for early COVID, right? So we actually, we just submitted an NIH research grant last month together with our colleagues at the Cleveland Clinic. At the clinic, they have a way of screening which drugs would have antiviral property. And it turns out that there's a estrogen receptor manipulator called torimifene, and then a melatonin agonist called tasimelteon. And so that's what we're going to test if it gets funded.
Good luck.
Those things are both oral meds.
So
Agreed.
we're down to the last question, okay? And don't worry about some of your questions. We will address it to the panel, and we'll send it an email.
Okay. I think Mike got lost. Mike, are you there? Just to take over, I guess, for Mike for the last question, Dr. Magalang. There's a question here regarding vaccination. If someone gets the vaccine, which is just 60% effective, and a second vaccine came on later, which is 90% effective, can this person get the second vaccine injected?
I actually answered the question in the chat box. You know, the FDA ceiling, and this is just what I heard, is this: the FDA ceiling for efficacy is 50%. So even if you get a 60%, and we don't know the true answer for this AstraZeneca vaccine, right? The 60% came from the group with the full dose. But if you combine the results, that's how they got the 70%. You probably, the answer is that you probably will not need the second vaccine.
Thank you for that, Miguel. Ted, are you still around, Ted, so that you could ask your LBC questions for the audience?
Yes,
Just a
I
second.
guess in closing, just before we, yes, could you guys hear me? Yeah.
Yes, we
Hello?
could. We could.
All
Yep.
right.
Go ahead. Go ahead, Ted.
Okay, so yeah, just so before we all I'll go in our separate ways. Well, let's just go ahead and finish off with the last two questions with the raffle promo for the gift certificate for one Sea Cargo Balikbayan box worth $100. Question number 2: where can you book for LBC's contactless and safe door-to-door Balikbayan services? Please send your answers with your name, email address, and the answer. Again, the question is, where can you book for LBC's contactless and safe door-to-door Balikbayan services? And the last question: how many years has LBC been bringing home smiles through its Balikbayan boxes and money remittance? Again, your name, email address, and the answer, please. Thank you.
Okay. Thank you, Ted. Ricky Rionda, can you close the program?
Yes. I don't know what happened to Mike. I guess he must have dropped off, but we're gonna announce the winners pretty soon. So you have a few minutes to put your answers into our chat room. And before we conclude, I'd just like to acknowledge all our speakers and panelists. Thank you so much for indulging us. And I'd also like to acknowledge the members of my production team, Brad Bong Vichanko, 81, our Zoom manager, and Dom Gonzalez, 84, who is our graphics and visual design manager, for job well done. So this would conclude our Zoominar for the night. And all our brads are requested to stay on if they want to for Zinuman.
Ricky, can I just announce the winners?
Oh, yes, please go ahead. Thank you.
Yes, so for the winners, we have Robert Key, Cecil Palanca, and Ana Pabalan for winning those 3 gift certificates from LBC. Congratulations. We will be sending you an email with the gift certificate. Thank you.
Thank you, brads.